Second white coat. Subscribe and like. Let's learn medicine together.
All right, today we're going to tackle a real-world medical puzzle. We've got a patient who needs a procedure, and our job is to figure out the precise anatomical roadmap to make it completely painless. So let's dive right in.
It sounds simple enough, doesn't it? But here's the thing. The face is wired up with this incredibly complex network of nerves. To get this right, you can't just take a wild guess. You need a map. You have to know the exact circuit to switch off.
So here's our case. We have a 58-year-old man, and he needs a biopsy on a little spot on his cheek that looks a bit suspicious. Our goal? We need to perform a nerve block, and we need to make sure he feels absolutely nothing. For his comfort and really for his safety, precision is everything.
Okay, take a look. This slide really zeroes in on our problem area. See that zone right there next to the nose? That's our target. And to numb it, we have got to find the one specific nerve that provides all the feeling right there. So how in the world do we find that nerve? Well, we use the body's own electrical blueprint, the trigeminal nerve system. You can think of it as the master controller for pretty much all sensation in the face.
It all kicks off from this one central hub, the trigeminal ganglion. Seriously, it's like the main power station. And from here, 3 massive circuits branch out to cover the entire face.
And from that main hub, the nerve splits into these 3 distinct territories. You've got one for the upper part of the face, one for the middle, and one for the lower part. Each one is a totally separate division with its own specific job. Okay, let's break that down. V1, that's the ophthalmic branch, and it covers the forehead. V3, the mandibular branch, that one handles the jaw and the chin. And right there in the middle, that's our guy, V2, the maxillary branch. It's responsible for the cheek, the lower eyelid, and the upper lip.
So, there we have it. We've identified our main circuit. Because that lesion is right on the cheek, we now know we need to follow the path of the V2, or maxillary nerve. We've just narrowed things down in a huge way.
All right, now for the fun part. We get to play detective. We're literally going to trace the V2 nerve from way deep inside the skull all the way out to the skin on the face.
This nerve's journey has 4 key checkpoints. First, it leaves the main skull cavity. Then it crosses this deep space behind the cheek called the pterygopalatine fossa. After that, it runs along the floor of the eye socket. And then, and this is the really critical part, it exits onto the face through a tiny little opening.
And once that V2 branch finally pops out onto the face, it gets a new name, the infraorbital nerve. And look at that. Its territory perfectly matches our patient's lesion, the cheek, side of the nose, and upper lip. We are so close to our target now.
We've followed the map, we've traced the clues, and we've finally arrived at our destination. The last step is to find the exact spot where this nerve becomes accessible for an injection.
And there it is. Look closely at this diagram. The nerve emerges from the skull through that little hole just below the eye socket. That opening is called the infraorbital foramen. That is our bullseye.
And this is just so cool. This is how perfectly anatomy translates into clinical practice. On the left, you see the diagram, but on the right, that's a real skull. A clinician can physically feel for this bony opening, which makes it an incredibly reliable and consistent target.
So here's the bottom line. By injecting anesthetic right at the infraorbital foramen, we block the infraorbital nerve the second it emerges. And with that one single injection, we effectively numb the entire cheek. Problem solved.
But why is this spot so perfect? I mean, why not somewhere else? You know, understanding the why nots is often just as important as knowing the why.
A really common point of confusion is the mental foramen, which is way down on the chin. But that's the exit point for a completely different nerve, V3, the mandibular nerve. If you injected there, you'd numb the chin, not the cheek. See? 2 different circuits, 2 totally different exits.
And it's the same story for other nearby openings. The superior orbital fissure, nope, that's for V1, which goes up to the forehead. And the stylomastoid foramen, that one's for the facial nerve, which has nothing to do with sensation. It controls the muscles you use for smiling. It's motor, not sensory.
So for any of you studying for exams, listen up. Here is your high-yield takeaway. If you see cheek anesthesia, your brain should immediately fire off this pathway. Maxillary nerve, which becomes the infraorbital nerve, which exits at the infraorbital foramen. It's simple, it's logical, and it works.
And really, that's the core principle you can apply to the entire face. To numb any area, all you have to do is identify the correct sensory division, V1, V2, or V3, and then just trace it to its unique exit point. It's a beautifully logical system.
So we've totally mastered the nerve for feeling. But that leaves one final question to think about. If the trigeminal nerve is handling all the sensation, what nerve is responsible for moving the face to actually create a smile? Now that's a puzzle for another explainer.